I'd like to now introduce the most recent addition to our faculty in the Retina service at the University of Wisconsin, Dr. Mihai Mititelu. Mihai will be speaking to us about one of the other major causes of retinal disease, proliferative diabetic retinopathy. He'll present an update on the treatment of proliferative retinopathy.
Thank you, Barb. Good afternoon, everyone. As Barb mentioned, my name is Mihai Mititelu. I'm one of the newest faculty members on the Retina service at the University of Wisconsin Department of Ophthalmology. And my talk today will focus on the updates on the management of proliferative diabetic retinopathy. I have no relevant financial relationships to disclose in relationship to this talk today. You know, we talked about diabetes all this afternoon, but what exactly is the definition of diabetes accepted by the medical community? As you know, or some of you may know, diabetes mellitus is a multi-system disease characterized by high blood glucose levels or hyperglycemia. Diabetes results from defects in the body's ability to produce and or use insulin, which is actually a hormone made by the pancreas. This is a, sorry about that. That's the gland pancreas that produces insulin. There were an estimated 285 million cases of diabetes in 2010, and this figure is expected to rise to 439 million in the year 2030. So we can say we have a pandemic at a global level. There are two types of diabetes. Type 1 diabetes typically affects children and young adults. Accounts for only about 5% of all patients with diabetes. Basically, in this condition, the body does not produce enough insulin. Type 2 diabetes is far more common. About 95% of patients with diabetes have this form, and it's caused by two main phenomena. The body does not produce enough insulin, or the cells in the body ignore the insulin. So this is known as insulin resistance. Diabetic retinopathy is one of the most common complications of diabetes. It's a progressive dysfunction of the retinal blood vessels that's caused by chronic hyperglycemia or high blood sugar. It is a complication of both diabetes mellitus type 1 and type 2. Initially, diabetic retinopathy is asymptomatic, so most patients do not know they have this condition in the early stages, and screening, effective screening for this condition with an optometrist or ophthalmologist is crucial for early detection. Later on, if the blood sugar is not well managed, it can cause low vision and blindness if not managed appropriately. Diabetic retinopathy, and I have a slide right there that shows, you know, all the blood and the dilated blood vessels in the back of the eye. So this is the basic diabetic retinopathy form. This is responsible for 1.8 million cases of blindness throughout the world. It is a leading cause of blindness, as a matter of fact, in people of working age in the Western world, like the United States. It's important to know that after 20 years of diabetes, diabetic retinopathy will affect virtually everyone that has a diagnosis of type 1 diabetes, and about 60% of patients that carry a diagnosis of type 2. There are two main forms of diabetic retinopathy. The first form that has the earliest diabetic changes in the back of the eye is classified as non-proliferative diabetic retinopathy, or NPDR, which Justin Gottlieb talked about earlier today. This also is associated with macular edema or swelling. If the blood sugar remains poorly controlled, the disease advances, and the most advanced disease is characterized by growth of new blood vessels, and this is termed proliferative diabetic retinopathy, or PDR. PDR, or the growth of new blood vessels, affects multiple compartments in the eye. You can see it affects the iris here, it affects the vitreous, the retina, the macula, and the head of the optic nerve. So it's a multi-system issue that affects multiple layers of the eye. This slide has a few photos of classic features of proliferative diabetic retinopathy, which, as I said before, is characterized by new blood vessels. These blood vessels grow in the corners of the iris, which is the colored portion of the eye. They also grow around the optic nerve, and also they grow around existing retinal vessels. This is called NVE, or neovascularization, elsewhere outside the fundus, outside the macula, excuse me. In PDR, the basic pathology is the formation of abnormal new blood vessels. And as you can see here, these are very dilated vessels that are normal growing around the optic nerve head. As these vessels progress, they tend to break easily and bleed inside the eye. This is a phenomenon called vitreous hemorrhage or intraocular hemorrhage, which is one of the causes of vision loss in diabetes. In terms of the mechanism of PDR, the basic phenomenon starts with retinal ischemia, which is basically a lack of oxygen to the back of the eye. In response to the lack of oxygen, multiple ocular tissues produce a protein called VEGF, which is a very important molecule in the study of ophthalmology these days. What VEGF does, it stimulates the growth of new blood vessels. These new blood vessels that you can actually see growing throughout the posterior pole of this eye grow between perfused and non-perfused retina, and they also grow into the vitreous, which is the gel-like substance in the cavity of the eye. There are two main causes of visual loss in proliferative diabetic retinopathy. The first of that I'm going to talk about is tractional retinal detachment, and this is because the new vessels that grow tend to have a fibrotic component to them, and they pull on the retina, leading to this retinal detachment. You can see here this classic fibrosis and scarring with the retinal detachment and the loss of the normal retinal landmarks. The second cause of visual loss in proliferative diabetic retinopathy is vitreous hemorrhage or vitreous bleed. And this happens because the new blood vessels that grow in the back of the eye are very fragile. They actually lack tight junctions, and they bleed easily in the cavity of the eye, leading to vitreous hemorrhage. Many times this represents a diagnostic challenge for us clinicians. We have to use special equipment such as a B-scan ultrasound to detect the amount of bleed and any other gross pathology that we cannot see in the back of the eye because of the bleed. And this is actually a section of an ultrasound. The white, the hyperreflective deposits in the vitreous are actually deposits of blood. In terms of treatment for PDR, historically there have been two well-established treatment modalities. They are still the gold standard. The most commonly employed one is in the form of argon laser, pan-retinal photocoagulation. We call it PRP. This involves application of several hundred spots of laser throughout the posterior pole in a 360-degree concentric fashion around the macula, and I'll show you a photo in just a second. In cases of advanced disease where you have a lot of blood and the retinal detachment, the management becomes more complicated and it involves a vitrectomy, which is basically a removal of the gel inside the eye together with the fibrosis, with the scar, and any associated blood. How does laser photocoagulation or PRP work? And this is a great question. We don't really know the mechanism exactly, but there are a few hypotheses. We know that laser decreases the production of VEGF, which I mentioned before is the molecule that occurs in states of hypoxia or low oxygen level, increased oxygen diffusion due to thinning of the retina, and also by providing a decreased oxygen requirement to the tissue, we have less of a stimulus for the development of new blood vessels. And this is actually the machine, one of the machines we commonly use for laser photocoagulation. The goal of the treatment is twofold. Number one, to arrest the development of new vessels, and number two, to induce regression of existing vessels and stabilize the level of retinopathy. There are many studies that have looked at the level of PRP or how much laser we need to apply, and the general consensus is that anywhere between 1,200 and 1,600 laser spots is adequate. However, PRP should be continued until regression of vessels occurs in order to prevent a bleed. And as you can see here, all these white dots are actually laser spots. They're evenly spaced, and they are sparing the central portion of the eye or the macula. We don't want to put any laser there because that may form a scar and give the patient a permanent blurry spot. One of the landmark studies that we use in ophthalmology, the DRS, or Diabetic Retinopathy Study, showed that PRP is actually a very effective treatment for PDR. PRP decreases the risk of severe SVL, severe visual loss, by about 50%. As mentioned before, the second option that has been historically employed to help with diabetic retinopathy that's very severe is surgery or vitrectomy. As you can see in this photography, the white debris is chronic blood or scar tissue in the eye, and that cannot be corrected by laser. So removal of the gel is a vitrectomy. It is employed in several situations, such as non-clearing vitreous hemorrhage, retinal detachment, recurrent vitreous hemorrhage despite maximal laser. Let's talk about VEGF for 1 minute. VEGF stands for vascular endothelial growth factor. And it's actually a protein, a molecule that is secreted by many types of cells, including platelets or vascular smooth muscle cells. It's a protein that's expressed after hypoxia or low oxygen state, and it's one of the best research molecules in ocular pharmacology these days. VEGF stimulates the growth of new blood vessels and also induces leakage from existing blood vessels, giving rise to macular edema. High levels of VEGF are associated with PDR. So knowing that the pathology of PDR starts with this molecule with VEGF, many researchers have asked the question if there's a role to VEGF blockade or inhibition in managing this devastating condition. And the question is actually yes. This question was answered by the DRCR-NET protocol. And as Dr. Blody mentioned earlier today, DRCR-NET stands for Diabetic Retinopathy Clinical Research Network. It's a collaborative network established in 2002 that comprises 109 sites in the United States, both academic medical centers and private practices. And it performs clinical research on diabetic retinopathy, be it macular edema, non-proliferative diabetic retinopathy, or PDR. It's important to know that the DRCR-NET is federally funded by the NEI and conducts some of the most rigorous research in diabetic retinopathy that we have out there today. The study that I was alluding to is termed DRCR-NET Protocol N. It's the first randomized controlled study that looked at the role of anti-VEGF in PDR. This study took place between 2010 and 2012, and it looked at both the effect and safety of intravitreal ranibizumab, or Lucentis, which is a commonly used anti-VEGF drug that is injected into the cavity of the eye. So compared the effect of safety of this medicine with injected saline on vitreous hemorrhage from proliferative diabetic retinopathy. There were several findings, and the most important ones that us clinicians use in current practice is that ranibizumab, or Lucentis, compared to intravitreal saline, gave the patients an overall better visual acuity. It led to fewer recurring vitreous bleeds, and also it increased the chance of completing laser treatment. Therefore, this medicine, clearing the blood in the eye, it allowed the provider to have a better view to the posterior pole and apply laser adequately to prevent the chance of a vitrectomy or the need for complicated surgery. These three findings have allowed us to determine that ranibizumab, Lucentis, and by extension its VEGF peers, Eylea and Avastin, have a positive biologic effect on vitreous hemorrhage from PDR. The DRCR-NET Protocol N also found that similar rates of surgery of vitrectomy between ranibizumab, or Lucentis, and intravitreal saline. These rates were about 15%, so really not that high, and this figure was overall lower than expected. Some studies quoted figures as high as 45 to 60%. So there was indeed a benefit. However, there was no statistically significant difference between the two molecules that were injected, Lucentis versus saline. Most importantly, the study told us there was no increased risk of tractional retinal detachment from scarring or fibrosis with intravitreal anti-VEGF in the setting of PDR. In conclusion, proliferative diabetic retinopathy is the most severe and blinding form of diabetic eye disease. Vision loss in this condition occurs primarily from an intraocular bleed and from a retinal detachment. Historically, the standard treatment has involved the use of laser, PRP, or surgery, vitrectomy. However, newer promising modalities such as anti-VEGF agents hold important promise in the management of this condition. And more research is needed to exactly look at the effect on growth of new blood vessels. And as always, we tell our patients in clinic every day, prevention of complications in diabetes is achieved primarily through good blood sugar as well as blood pressure control. And that's all I have. Thank you.